Yes, this is indeed a new concept. It has been discussed for long. Thoracic radiotherapy was proven in a meta-analysis to be beneficial in limited disease small cell lung cancer. It's a standard now. And there has been a debate whether the same effect might be achieved in extensive disease. Despite dissemination of the tumor, thoracic disease is still the largest mass in small cell lung cancer. So there were some, I would say, arguments to consider it. And the Dutch group performed a very interesting randomized study investigating this concept, comparing standard therapy, which is systemic therapy alone with cranial irradiation versus the same with addition of thoracic irradiation. And surprisingly, there is some benefit from thoracic radiotherapy. So, of course, this study necessitates a little bit longer follow-up. The benefit was seen only after 2 years. So the curve diverged after 12 months. But this is an important message, and we should consider it again as an important progress in this category of patients, which have particularly poor prognosis. This is a little bit a surprise. A Korean study showed that there is no benefit of cranial irradiation, prophylactic cranial irradiation in extensive disease small cell lung cancer, which is in contradiction with the previous Slotman study. By the way, the radiotherapy in extensive disease small cell lung cancer was also presented by Slotman. So he's a guy doing large, important practice-changing studies in small cell lung cancer. Coming back, prophylactic cranial irradiation was shown to provide no benefit in terms of overall survival. The study was stopped due to futility analysis. And so the question now is how to treat this patient, because we have one clearly positive study and one clearly negative study, and the difference is probably that we have now more diagnostic tools. All these studies in the Korean study were underwent MRI, brain MRI before entering into the study, so some asymptomatic brain metastases were found. This was not the case in the previous study. Maybe there are some other differences. There's a different population of patients. There might be some ethnic factors, but the message is here. So we have to consider this study seriously. Yeah, there has been no new drug for decades no new drug for decades in small cell lung cancer. The study that was presented here showed that standard second-line therapy with teniposide is probably less effective than a triplet, including 2 standard drugs. This is etoposide, cisplatin, in addition, and the third drug is irinotecan. Irinotecan has been tested in several studies in small cell lung cancer, and some of these studies showed some benefit, but it still has not been considered a standard. Here we see that there is an important difference, important benefit of using triplet rather than a single agent teniposide in second-line therapy. So again, this might change the practice. Yes, consolidation chemotherapy after chemoradiation in stage 3 non-small cell lung cancer has long been a subject of debate. And in this country, in the United States, it was considered until recently a standard. Our American colleagues used docetaxel in consolidation therapy. This strategy was shown to be ineffective, and I believe this practice is not continued anymore. And this new study showed and investigated the effect of doublet, including docetaxel and cisplatin or carboplatin as the consolidation therapy after chemoradiation in non-small cell lung cancer, and again showed absolutely no benefit. So these patients are really tired after intensive chemoradiation, and they deserve some vacations. And it's a good news for them that this very toxic therapy is not necessary in this setting. There are many good news for non-small cell lung cancer patients. Non-small cell lung cancer is becoming a mixture of several diseases with various molecular features, and EGFR mutated tumors is one category, it's the largest of those, but also ALK-positive, MET-positive tumors, and much more HER2-positive tumors. And all these patients will necessitate different molecular therapies. This is obvious because they have different molecular targets. And introducing anti-EGFR therapy was a real breakthrough in EGFR mutated patients. The same was true for ALK-positive patients and crizotinib. Now we have several new compounds that are effective both in first and in the second line treatment of both categories of patients. For example, seritinib was found to be very effective in ALK-positive tumors, both in first and in the second line. We have also several drugs that are effective in EGFR-positive tumors. That means that these patients may continue therapy, anti-EGFR therapy much longer before they totally relapse and will necessitate chemotherapy or some other therapies. So this is indeed a very good news. I would say interesting data for lung cancer, both for non-small cell and for small cell. The studies I addressed may change practice. All these studies are potentially practice changing. So this is always important. If you consider new data in these categories, they are indeed important.